So we use surgery for ulcerative colitis if they have cancer or if they fail all available therapies. For modern treatment of inflammatory bowel disease, we use a treat to target approach, and the targets are three.
Puerto Rico, la casa de Public Health LATAM. Ciencia y salud para todos.
Thank you for joining us on the coverage of the Guild Caribbean Conference 2026. We have the honor of having with us now the program chair of the conference, Dr. Uma Mahadevan. How are you?
I'm great. Happy to be here.
Oh, and this is the first time in Puerto Rico, right?
It is. It's the third Guild Caribbean, and we were initially in Aruba, St. Thomas, and now Puerto Rico. We love Puerto Rico. We'll be coming back next year.
That's wonderful. How many professionals have you managed to have here during the weekend?
So today we have about 135 physicians and advanced practice practitioners here, which is great. The meeting is growing, and we expect to hit 300 in the next couple of years.
Which are the main topics or main areas of interest for the community?
So we have 2 days of inflammatory bowel disease, Crohn's disease and ulcerative colitis. We have 1 day of liver disease, and we have 1 day of general gastroenterology, which includes eosinophilic esophagitis, colon cancer screening, pancreatitis, etc.
So on those topics specifically, what are, let's say, the most advanced therapies or breakthroughs we've seen during the last decade?
So that's a lot. So I would say for inflammatory bowel disease, we have seen multiple new classes of medications, the IL-23s, the JAK inhibitors. We also have new mechanisms that are being studied, like the TL1As and obefazimod. The way we start out each day is we do a 1-hour best of year-end review. So today was Crohn's disease, tomorrow will be GI, Tuesday will be ulcerative colitis, and Wednesday will be liver disease. And in liver disease, there are also many, many new advances, including in MASLD or fatty liver, even using Ozempic for fatty liver disease, which has been approved, as well as new medications for PBC.
And it also means that there are a lot of alternatives for physicians and patients, and that's wonderful, because everything can be tailor-made or personalized for the patient and their condition.
Correct. And we do spend a lot of time going through guidelines and algorithms of how you have patient X and what are the questions you ask and which way down the algorithm you go based on their disease course and what therapies they've been on.
Oh, you mentioned it a while ago, but when managing these inflammatory bowel diseases, what are the main pillars of modern treatments today?
For modern treatment of inflammatory bowel disease, we use a treat to target approach, and the targets are three. The first target is getting them to feel better, so the symptoms. The second pillar is endoscopic healing and response. So when you scope them, you want it to look better. You also want their biomarkers, their CRP, their calprotectin to improve. And eventually, at some point, we may be looking at histologic healing, to have healing at the biopsy level.
When do clinicians, or how do clinicians decide when to begin biologic or targeted therapies in these patients with IBD?
So we go over that in great detail, because now there are great guidelines both from ACG and AGA, and it really goes not by how long they've had the disease, but how severe it is. So if you have somebody diagnosed yesterday and they have moderate to severe disease, they are best off with a biologic. And the reason for that is you want to improve their quality of life, and you actually want to modify disease. You want to see that you can prevent future flares, you can prevent surgery, you can prevent even cancer by having less severe disease.
So this means that we have less surgeries now because we have more options?
Absolutely. There are far less surgeries for ulcerative colitis, for colectomy, than there used to be given infliximab and the JAK inhibitors.
When is it necessary?
So we use surgery for ulcerative colitis if they have cancer or if they fail all available therapies. And then for Crohn's disease, again, if they fail therapy, if they have cancer, but also if they have strictures.
What's next during the couple of days that you still have of this conference, coming back and seeing if there's somebody out there who still can join you during these next days?
Yeah, so tomorrow we have 4 great speakers. Tyler Burzin from Beth Israel, who's going to be talking about EII in gastroenterologic diseases, as well as autoimmune pancreatitis. Audrey Calderwood, who's going to be talking about colon cancer screening. Evan Dellin, who's going to be talking about eosinophilic esophagitis. And Sarah McGill, who's going to be talking about alpha-gal syndrome, something I'm looking forward to hearing about because I don't know a lot about it.
Well, thank you very much, Doctor, for inviting us and letting us be part of your activity and helping the public learn more about these new treatments.
Thank you so much. I'm very happy to be here, and hopefully we'll see more people from Puerto Rico at next year's course.
Oh, well, we'll be waiting for you next year. Thank you very much.
Thank you.
And if you want more information on health issues and specifically IBD, you can tune in to our website, phlatam.es.com.